My talk today will be clinical advantage of the OCTA in retinal disease management. I'm sure we're all familiar with OCT. The basic principle is that it's a three-dimensional non-invasive imaging technique with high spatial resolution and great depth penetration. But essentially it's based on two basic fundamental principles: the measurement of the reflected light from tissue discontinuity as well as interferometry, which is really the interference between the reflected light and the reference beam used as a coherent gate to isolate light from specific depth. We are all very familiar with the OCT angiography angioplex from ZEISS. Essentially, it's not new. It is a non-invasive microvascular imaging technology, which really allows visualization of both the perfused vasculature and vascular abnormalities of the retina without the need for contrast. Again, the angioplex detects motion of scattering particles like the red blood cells within the sequential OCT scan performed repeatedly at the same location acquired using the FastTag technology. The data is processed powered by the OMAC or the optical microangiography. Each cluster generates one blood flow scans, constructing them into a map of a perfused microvasculature within the retina and as well as of the choroidal system. This angioplex map consists of a two-dimensional representation of retinal vasculature of a particular region or slab of interest. You can see it can be divided into a superficial, deep, and avascular retina, denoted by the red, green, and blue color respectively. This is a typical representation that you can see on the screen. On your left-hand side, you can see that there are 10 presets in the center, the angioplex, which I'll talk about after this, with a corresponding B-scan at the bottom, as well as a on-fast slab on your right-hand side. So what are the usefulness and potential clinical application that can use the angioplex from ZEISS? This angioplex can potentially be used to detect vascular structures, for example, like retinal pathology, like in diabetic retinopathy, in vein occlusion, both central and branch vein occlusion. We can also be used to detect abnormalities in macular telangiectasia, abnormalities of optic nerve vasculature, and not forgetting choroidal pathology like in CNV in AMD cases. Let's look at the first most common microvascular abnormalities like diabetic retinopathy. Again, we are very familiar with the use of OCT in diabetic retinopathy. Again, this can be OCT used to find the cause of the visual impairment, for example, like retinal edema. It can also look at vitreomacular relationship and traction, confirming extent and indications for therapy, for example, like lasers, intravitreal in this day and age, and of course, surgical therapy. We are also familiar with the use of fluorescein angiogram, looking at microvascular abnormalities, for example, in microaneurysms, intraretinal microvascular abnormality, and differentiating it from, for example, neovascular TAF like neovascularization. We can also look at areas of non-perfusion or increase in the foveal avascular zone from macular ischemia. So can we use OCTA like fluorescein angiogram to look at locations of microaneurysms, looking at other diabetic microvascular changes, or determining areas of non-perfusion in diabetic retinopathy? Let us look at some clinical case examples. A typical case example of diabetic retinopathy where you can see diffuse dot plot hemorrhages in the center as well as periphery. This is a magnified view of the patient. You can see evidence of retinopathy with a dot plot and exudates. How can we use the OCT angiogram or the OCTA or the angioplex? Here with a superficial slab, as you can see, looking at the superficial slab, looking at the center, we can see there's enlargement of the foveal avascular zone, destruction of the pericapillary plexus. Again, at the inferior temporal aspect, you can see some microvascular changes as well and peripheral ischemia in this superficial slab. I just want to draw your attention to the pathology within the 6 green circles. You can see we don't see much pathology on the superficial slab. However, if you delve deep into the deep slab, we can see this microvascular telangiectatic vessels changes that we did not see in the superficial slab. If you combine the two, superficial and deep slab, color code them on the retinal slab, we can see where the pathology lies because of the color coding, the depth and coding that you can see here on this color map. If you superimpose back the colors, we don't see these microvascular changes on the color photographs, which you can see quite clearly, distinctly in the angioplex. Thus, we know that microvascular abnormalities and alterations can can begin very early, and OCTA is able to detect such vascular changes even without clinically detectable diabetic retinopathy. How about looking at intraretinal microvascular abnormalities? Here is the patient's other eye, the left eye, which shows a bit more florid retinopathic changes with more hemorrhages. Again, a zoom-in picture and magnified view of the posterior pole, you can see the hemorrhages quite clearly. How do we apply and what can we see from the OCTA in the left eye? Here you can see again the enlargement of the foveal avascular zone, but other new pathology like superiorly you can see this ulmus or intraretinal microvascular abnormalities. Temporal to this, you can see that there are some microvascular and telangiectatic vessels on this superficial slab. Again, drawing your attention to pathology within the green circles, we do not see much pathology, but if we delve deep into the deep slab, you can see new and other distinct microvascular changes. Combining the two again and adding some colors in this deep encoded slab, you can see where the pathology lies based on the different colors representation. This patient probably has at least a severe diabetic retinopathy evident by the pan-retinal photocoagulation scars that you can see. Again, a zoom-in magnified view of the posterior pole. We don't see much hemorrhages, but you can see the scars. Probably patient had a focal and grid laser done. Again, the superficial slab will reveal such telangiectatic microvascular changes of microaneurysms. But how about the deep slab? You can see much more microvascular abnormalities in the deep cuts and deep slab. So thus exhibiting a significant damage to the integrity of the deep capillary plexus, but not so much of the superficial capillary plexus. Again, we know from previous study that the pathology is mainly and more significant, more evident in the deep capillary plexus as compared to the superficial capillary plexus, as you can see from this picture. Here is a depth encoded slab as well, where you can determine the levels of the pathology based on the color coding. Again, going back to the color photographs, you do not see those pathology or microaneurysmic changes, telangiectatic vessels in the color fundus photograph. So how about patients who develop new vessels or neovascularization? Are we able to apply the OCTA to determine these new vessels? Apologize for this slide. Patient has quite a bit of cataracts. But here, not applying the superficial or deep slab on this patient, but we want to apply the vitreous slab or the VRI or vitreoretinal interface slab. Here we can see there's a flow abnormality. Again, I just want to show an enlarged view of the B scan showing that this slab is just above the superficial retina and doesn't include the retina, but we can see on this enlarged view of the VRI picture, we can see this flow abnormality. But here again, on the lower border of the slab, I just want to include a little bit of the superficial retina, where you can actually see that these flow abnormalities that's highlighted in the earlier scan has a relationship with the superficial retinal blood vessels. So this is actually an NVE or new vessels elsewhere that has protruded into the vitreal cavity. So we do know that retinal neovascularization is seen and protrudes into the vitreal cavity. This distinguished from the intraretinal microvascular abnormalities we've seen earlier on, which essentially is intraretinal and does not extend into the posterior hyaloid. Again, this photo of the patients with the new vessels elsewhere, and you can see the superior temporal aspect where the NVE lies. This patient probably also has at least a severe diabetic retinopathy evident by the pan-retinal photocoagulation scar, but it's really exciting that on top of using the OCT, again with the ZEISS Claris 500 pad, not only can I see a posterior fundus view, a nice clear true color posterior fundus view, but again with a montage of this, I do have a wide field or even an ultra wide field. Combining this with the new Series 6000, where it gives me a faster scan speed, where we can actually achieve 100,000 OCT and OCT-A scans per second. This translates to 270% faster OCT scan, 43% faster OCT-A scans, as well as to acquire an OCT cube takes less than half a second. And it's really exciting and thrilling for the past 5 years to really start off with the ZEISS Series 5000, moving on now to the Series 6000 for a wider scan. Unfortunately, today I won't be sharing my experience with the Plex Elite 9000, where really it's a swept source technology to really give me a really wide field OCTA other than a scan. And just to quickly share about the 6,000 angioplex, not only can I get the 3x3, 6x6, and 8x8 millimeter scan, but a montage of it will give me a 14x10 as well as a 14x14 millimeter wide field OCT angiogram. Here, we're 14x14 montage with 5 of those 8x8 OCT-A scans and a 6x6 scans combination montage giving me a 14x10 millimeter picture. Back to this patient, where we can see there is evidence of a pan-retinal photocoagulation scar. What can we see when you apply the OCT-A on this patient? Again, you can see the B scan at the bottom inferiorly where this patient has cystoid macular edema, and we just focus on the superficial slab. Yes, we do see more clearly the macular edema in this patient is this 8x8 slab, but if we combine the 8x8 slab and giving a superficial montage, we actually can see the peripheral ischemia, which we are unable to do so with just a single central 8x8 cut. Again, taking away the rest of the montage, we do miss a lot of peripheral ischemia, which really will determine the prognosis of the patient with severe ischemic diabetic retinopathy. Combining the OCT-B scans, we can see here we have a high definition 20-line fine line raster. And again, if I do want to see more clearly, I can have the horizontal and vertical fine line raster to determine the areas and volume and extent of the macular edema that this patient has, other on top of the OCT angio, which determines the ischemic areas that we have seen earlier on. Going to the patient's left eye, what can we see? The patient actually had undergone a vitrectomy for a vitreous hemorrhage. You can see the extensive and intense laser burns on this patient's eye. Here, applying an 8x8 superficial slab, again, we do see the macular edema, but patient does not have much of the microvascular changes. But if we apply the superficial montage, giving rise to the 14x14 from the multiple 8x8, we can see vascular loops as well as peripheral ischemia, which the central 8x8 does not allow us to visualize. Again, focusing on just a 6x6 over the fovea, we can able to determine the macular edema, but we do miss a lot of peripheral ischemia, which only the montage from a 14x10 from 5, 6x6 would be able to achieve. Here again, we do see the vascular loops as well as the peripheral ischemia in this patient. We can also zoom in the area of interest. For example, I want to localize and look at the areas of vascular loops and the pathology around it. And here you can see the slice navigator and the crosshair over the area. And again, I can do a video clip of this. The scans you can see going down, and then from the top, it goes down to the bottom. And as it approaches the area of the vascular loop, we can see slowly a hump or protrusion into the vitreal cavity coming up, associated with increased blood flow. The rest of the retina you can see is fairly normal. Here is a picture, a still shot, where you can see that it cuts through the vascular loop, and around the structure of the vascular loop, we can see this protrusion around the vascular loop with increased blood flow. So this is the area corresponding to the white area that you see on a color funded photograph, the fibrovascular membrane, indicating this patient has NVE, new vessels with increased blood flow on the OCT-A, as you have seen. So how about abnormalities of optic nerve vasculature? Can we use the OCT-A? This patient probably has some resolving vitreous hemorrhage and definitely proliferative diabetic retinopathy. You can see also huge areas of laser scars extensively in the periphery as well. But we want to zoom in on the optic nerve in this patient's eye. Here, instead of using a 6x6 or 8x8 over the fovea or macular region, we zoom in on the optic nerve head. Here is a high definition angiography with a 6x6 cuts. And here you can, again, with the VRI or the vitreoretinal interface to isolate the vitreal pathology. Just a magnified view, zoom in view, that the cut or the slab is just above the superficial retina into this pathology that is protruding into the posterior hyaloid. Here, adding a little bit of flow, you can see that there is increased blood flow into this pathology. So isolating this pathology from the superficial retina in the VRI cut or vitreoretinal interface, we can see this nest or network of new vessels at the disc in this patient. Can we use OCT-A in vein occlusion? Here you can see a typical example of a supratemporal retinal vein occlusion evidenced by the flame as well as blood hemorrhages. Here in the early frames of this vein occlusion, we can see ischemic areas and capillary dropout. Here in the late frames, we can see vascular insufficiency. Again, a magnified zoom-in view where it's showing vascular ischemia. How can the OCTA help us in a vein occlusion or branch retinal vein occlusion? And this example, here is a superficial slab where you can see the demarcation of the superior ischemic areas versus the inferior non-ischemic area. There's a clear boundary where the vein happens, a vein occlusion happens. And again, on the deep slab or deep cut, again, you can see a very clear demarcation of the vascularized inferiorly as well as non-vascularized superiorly. Just want to draw your attention to the areas indicated by the green circles. These are areas of vascular congestion, which usually occurs at the margin of the non-affected and the affected area. Again, just to show the deeper cuts like the choroidal capillaries, the core capillaries, as well as choroid will be free from this pathology because it's mainly localized to the retina. How about in central retinal vein occlusion? Evidence is patients with vascular tortuosity, hemorrhages, as well as ischemic looking retina. Here in the early frames of the fluorescein angiogram, we do see ischemic areas, capillary drops out, as well as blood fluorescence from the hemorrhages, as well as the late frames, you can see the venous and vascular tortuosity. Again, the reduced blood flow on the nasal aspect would be from the ischemia as well as this from the superficial cut. And if we look at the deep cuts, again, I just want to draw attention to the pathology within the green circles, and you can see some vascular congestion in the deep plexus. Here, again, I just want to bring you back to the superficial cut where we do not see those vascular congestion. Again, we do and slowly begin to understand the absence of venous collaterals identified entirely within the superficial venous plexus suggests the preponderance of retinal venous drainage causing through the deep vascular plexus. And these plexus are probably the principal, and these deep plexus are probably the principal venous outflow system for the retinal capillary plexus. So these deep venous complex are usually where the collaterals and eventually new vessels develop, and not so much on the superficial venous plexus. So what happens to patients who have central retinal vein occlusion that has been treated with multiple intravitreal injections as well as pan-retinal photocoagulation? Here they develop collaterals over the disc. So just to show some optic nerve pathology again, we can have a 6x6 superficial OCT-A scans, but in this case, I do want probably a magnified and zoom-in detailed view of the optic disc with a 3x3 cut. Again, a magnified view of the 3x3 superficial slab has a better details as compared to the 6x6 superficial cut. Again, the 3x3 deep cuts as well. And combining the superficial and deep cut, we are able to determine the levels of the collaterals with the color and coding like we see on this picture. Another examples of patients with a vein occlusion, inferior vein occlusion, where you can see a sclerosed vein inferiorly. But however, this is where I also enjoy, for example, the Clarus 500, where you have true colors, where you actually see the sclerosed vessels better. Again, you may be able to see the pigmentation or the wedge-shaped pigmentary change of the retina, which is around the area of the sclerosed vessels. So here, the superficial montage 8x8 giving to the 14x14 will show the area of capillary dropout or ischemia on the OCTA. But really, we're interested in the opposite eye. Again, this is a very clear branch retinal vein occlusion with the sclerosed vessel and extensive and intense laser scars that has been applied. Here, the superficial montage will again show a very clear boundary and clear demarcation of the perfuse inferiorly and non-perfuse superior temporally. Again, a clear demarcation on the superficial and again the deep montage on this wide field 14x14 OCTA. There are not many studies and pictures of in the literature of arterial occlusion, probably because of difficulty in capturing and the long acquisition time and the poor fixation the patient has in arterial occlusion. This elderly lady with hypertension presents with vague patchy vision. Interestingly, you can see there's pale-looking retina superiorly, with some areas of hemorrhages. And it's because the swelling and the whitening of the retina is not just confined to the superior temporal area, but again, on this white field, you can see almost the whole superior aspect of the retina is wiped out and edematous. Interestingly, the fovea, the macular area, is relatively spared. This is a serial fluorescein angiogram. You can see the first frame on the top right. You can see that the almost entire top half of the fluorescein angiogram is devoid of vasculature. You can see there is an increased arm retinal time or increased transit time. I can see that the flow in the top superior retina is actually slowed as compared to inferiorly, and you can see it fills up eventually. So this is a superficial montage of the 8x8 given a 14x14, where you can see flow deficiency superiorly. And if you look closely at the fovea, it looks pretty intact because the patient has fairly good vision. This is a video I just want to show moving from left to right, where you want to compare the superior and inferior retina. You can see on the B scan moving below, where the swelling of the superior retina versus the inferior normal retina. The rest of the temporal retina looks normal. The superior retina is demarcated by the red arrow. You can see the swelling, and the normal retina demarcated by the yellow arrows. Again, you can see the swelling of the superior retina from the ischemia as also decreased flow volume as compared to the normal flow in the inferior retina. Again, combination with the B scan, you can see that there is a haphazard kind of disorganization of the retina due to the hypoxia and ischemia from the arterial occlusion. Again, the hyperreflectivity of the inner retina layers combined with the hyporeflectivity of the inner retina showcase the disruptions of the whole retinal structure from hypoxia from this arterial occlusion. Here you can see the rarefaction of the OCT signals is clearly seen here on this P scan. Can we also apply OCT-A on macular telangiectasia? Here is a typical example on this photograph of macular telangiectasia. The clinical signs are that of the opacification of the retina with a parafoveal gray sheen. There's also retinal pigment epithelial hypertrophy, as well as you might see some crystalline deposit if you look closely. So what can the OCT-A show? Here is a superficial slab where you can show there's invasion of the foveal avascular, which is, as we know, is supposed to be avascular. Again, on the deep slab, a deep cut, you can see a deeper penetration of this FAZ. Combining the two in a retinal scan, deep encode them, you can see that the invasion of the FAZ in this patient with the macular telangiectasia type 2 is also into the avascular and deep areas of the retina. How about the patient opposite eye? Will it show us the same pathology? Yes, we do see the opacification of the retina with the parafoveal gray sheen as well as this retinal hyperpigmentation. However, we do not see much of the crystalline deposits. Here on the superficial slab shows a different pathology starting with the B scan and not the angioplex OCT-A. Here we can see there's intraretinal cavitation arising due to the neural atrophy and disruption of the foveal structure. And we know that the primary pathology is probably the result of destruction of the Macular cells in this case, giving rise to the classical sign in macular telangiectasia of ILM trait in this P scan. And the OCTA again shows a typical macular telangiectasia where there's focal dilatation and alteration of the foveal capillaries, most prominently, as you can see, temporally in the patient's left eye. Again, on this superficial and deep cut, we can see this focal dilatation. Combining the two, we can see that the pathology is not only superficial and deep, as well as going deep into the avascular area, as you can see by the blue color in this depth encoded color slides. Again, courtesy of Professor Phil Rosenfeld, comparing the fluorescein angiogram and angioplex, we can see the abnormal vasculature to the temporal fovea. So the angioplex really maps and highlights the region of abnormal vasculature within the retina of this bilateral pathology, macular telangiectasia type 2. So we have seen the potential clinical applications of the angioplex to detect vascular structures like in retinal pathology, like in diabetic retinopathy, in vein occlusion, both branch and central, as well as arterial occlusion, not forgetting also looking at macular telangiectasia abnormal vasculature. as well, we also saw case or one or two cases of abnormal optic nerve pathology. How about, can we use the OCTA looking at the capillaries and choroidal pathology like in CNV in AMD? What are the clinical advantages of OCTA, not just in retinal pathology, but choroidal disease management like in AMD? So next I'll talk about age-related macular degeneration. This patient, you can see a posterior pole photo showing patchy subretinal bleeding hemorrhages. Early frames of the fluorescein angiogram shows a early leakage over the center, as well as some stippling and late leakage around it. Here, if we apply the superficial slab as well as a deep slab, we should not see the pathology because this would be a chorocapillary or choroidal pathology. Here you can see above the RPE, highlighted within the circle, within the yellow circle, where we can see this abnormal nest or network of abnormal vessels. Here we can see a corresponding B scans showing clearly that this pathology is above the RPE. This is indicated by the yellow arrow. And if you look at the blue arrows, you can see some pathology to the side of these yellow arrows, where you can see these pathology indicated by blue arrows are actually below the RPE. If we put on the fluorescein angiogram slab again, we can see the yellow pathology indicated by the yellow, within the yellow circles, showing early hyperfluorescence, indicating this is a classic or type 2 pathology. Going below the RPE, we can see the pathology within yellow circle is not that obvious below the RPE, but the surrounding pathology around it, which is demarcated by the blue circles, which is the occult or below RPE or type 1 occult pathology, is actually more obvious. So this is really a mixed picture using the OCTA determining the level of pathology of the choroidal neovascular membrane. This patient has probably a vague, non-distinct kind of hemorrhage over the central fovea. When you apply the OCTA, again, in the early frames, not a very huge, florid, vigorous kind of leakage in early frames, and even on the late frames, does not show extensive hyperfluorescence. Again, this pathology is not in the deep layer, but if you apply the chorocapillary slab on the OCTA, you can see a C-fan kind of neovascularization, this chororetinal, this choroidal neovascular membrane clearly seen here. And again, if you apply the B-scan, you can see the pathology is really below the chorocapillaries, giving rise to the late leakage that we have seen in the fluorescein angiogram. This next picture has some subretinal hemorrhage, but it also has a mixed picture of chronicity. Some signs of chronicity determined, as you can see, by the atrophy, the fibrosis, and the scarring around the hemorrhages. Late frames of the fluorescein angiogram, again, does not show any much florid hyperfluorescence, even in the mid frames, but only in the late frames you can see this late leakage, giving rise, suggesting a occult kind of pathology. Magnified view of the photograph here, again, and if you apply a OCTA of the chorocapillary slab, we can actually see a very mature, well-defined trunk, as well as branching pattern and loops of choroidal CNV or choroidal neovascular membrane here. Again, if we go in a bit deeper in the choroidal pathology, we do see a different kind of also fairly mature branching kind of network and pattern of this choroidal pathology. Combining the two, we can see a very mature looking second kind of trunk with loops and branching of this whole choroidal membrane. Again, going back to the fluorescein angiogram, where the areas of leakage is a magnified view, as you can see within the yellow circle. And again, if we apply the angiogram, we can actually see that this is exactly where the abnormal choroidal vasculature is or originates from. This patient has also a little bit of subretinal hemorrhage in this left eye. Fluorescein angiogram in the first 4 frames will show early leakage as well as hyperfluorescence. The last 3 frames are actually of the opposite eye, which really shows some hyperfluorescence, but mainly staining in nature. In this part of the world, we do, and I do routinely do indocyanine green angiography or ICG, because we do see quite a number of polypoidal choroidal vasculopathy or PCV. Here, this patient does not have any PCV. Here, applying the OCT, we can see 8x8 mm cuts. We can see a very well-defined choroidal picture. Just want to share that with the Series 6000, not only do we have the already 10 presets, but in addition, they also have a ORCC or outer retina chorocapillary slab, as well as RPE and RPE fit slab, as well as a sub-RPE slab to really look at areas and really to fine cut areas around the RPE. Here I'm using the oral CC map or the autoretinal chorocapillary map or slab to just showcase the choroidal, abnormal choroidal vasculature. Here with a 6x6, I do want to have a close-up view, a more detailed view, thus a smaller, more detailed kind of picture of the OCTA. Here you can see with more details of the choroidal pathology. Interestingly, we want to go look at the opposite eye of the patient. Again, in this photograph, patients does not have any hemorrhage, unlike the opposite eye we have just seen early on. Patients in this posterior pole photograph probably shows a little bit of hyper and hypopigmentation and maybe a little bit of drusenoid changes, but without any hemorrhages. The B scan shows that there is a little bit of undulation of the RPE with hardly any swelling. Here we can see, applying the OCTA, we can see with the 8x8, we can already see a abnormal choroidal vascular network in the oral CC cuts. Here on these, a little bit of more details on the 6x6 cut, zooming in on this choroidal pathology, we can see already in this asymmetric eye, patient actually has a 6/6 20/20 vision, devoid, does not have any metamorphopsia or distortion, and already has developed a fairly clear and distinct chorocapillary abnormalities, as you can see here in the chorocapillary cuts. So it's very important to follow up in this patient who already has a CNV on one eye and a non-exudative, fairly non-exudative pathology in the opposite eye with good vision. And it's important to educate the patient of this pathology in both eyes. This patient also shows a little bit of retinal, subretinal hemorrhages associated with some exudate, as you can see temporally. Again, once the fluorescein angiogram determines the hyperfluorescence or the choroidal neovascularization, we can also apply the OCT slab. Here, I'm using the RP Fit slab, and with that slab and with the Series 6000, I can actually delineate quite clearly, marking the areas of the CNV. And this is really useful for serial follow-up of the patients, whether progression or regression of the CNV. Combined with the B scan to look at the volume as well as the thickness or the swelling of over the area, we can actually determine the progression or the success of the intravitreal treatment or whatever treatment that we apply on this patient serially. Interesting also to look at the patient's opposite eye. This is the same patient that has CNV in the left eye. Again, on the fundus photograph of the right eye, we can see that probably is a bit of cystic changes of the posterior pole. Here in the fluorescein angiogram, there is look like an ink blot kind of hyperfluorescence. And applying the B scans that we have on the Series 6000 with this fine line cut, a fine line raster of both the horizontal and vertical, as well as the 21 fine line high definition cut to look through the areas of the swelling. This is really a subretinal swelling or the central serous called retinopathy. You want to determine that in this elderly gentleman is just a pure fluid collection of CSR and CSCR, and there's no choroidal pathology. Looking at the integrity and the distinct intact RP layer, we can really determine that this is just a pure CSR. Again, looking at the individual slab, making sure there's no pathology as we have seen in the earlier slides of chorocapillaries as choroidal pathology, the oral CC, the subretinal, as well as the chorocapillaries, there's no abnormal choroidal vasculature. So applying the OCTA in age-related macular degeneration, we have confirmed CNV in the first few examples. We also excluded CNV in the last patient, where patient only presented with a CSR or CSCR in the opposite eye with the CNV. We also can determine the level of involvement of the CNV or the choroidal neovascular membrane, whether is it above the RP layer or below the RP layer. We can use it to diagnose and monitor non-exudative CNV, for example, in the second last case. And again, finally, we can also use to monitor effectiveness of treatment by measuring the size of CNV corresponding with the B scan swelling. I'll end on my talk to say, why is OCT angiogram so important? Again, the advantage of the OCT angiogram, this is not really affected by the hyperfluorescence or oversaturation that you can see in fluorescein angiogram. Again, on the picture on the left-hand side, you can see a very distinct new vessel in this patient, proliferative diabetic retinopathy. But again, this picture of the new vessel is masked by the hyperfluorescence of this fluorescent angiogram or the picture on your right-hand side. We know in angio, OCT or OCTA, there really is no leakage, staining, or pooling. The vessels are clearly seen, as you can see earlier on, and not blurred by any leakage. And very importantly, OCT can be performed many times, not just in different settings, but even within the same setting if the image quality is not captured properly. Again, we have seen that the second advantage of the OCT is the angioplex map, which is essentially a representation of the retinal vasculature at a particular slab or region of interest. Because it captures the B scan and measures the blood flow simultaneously, registering together with the on-fast angiographic map, which means that the retinal blood flow and structure can be evaluated together, combined with the on-fast OCT image segmented to enable visualization at the various retinal depth denoted by the different colors, the superficial red, deep with green, and avascular by the blue colors. Here it can accurately reveal the exit location, for example, even a choroidal pathology, as well as allowing monitoring of the size, progression, or regression. The weakness or disadvantage of the fluorescein or dye-based angiography would be advantage of the angio-OCT. We know that the reasons for false negative, for example, in a dye-based angiography, could be due to blood or blood fluorescein from subretinal or even intraretinal hemorrhage. Here, I won't speak very much about it, but for example, in a swept source OCT has an advantage in the sense that we can look beyond the intra or even subretinal. Here, we do want to see the integrity of the RP behind and beneath the intraretinal and subretinal blood. Again, we do know that dye-based fluorescein angiogram or even indocyanine green can be contraindicated in allergies on pregnancy or renal diseases, but we can apply this non-invasive OCTA in patients with these problems. I believe we do know that it's a doctor's wish who perform serial injections and intravitreal injections. We do want to perform the OCT regularly together with injection, but we also want to be able to have an angiographic picture of the patients every time we do the injection to monitor the effects of the previous injection. But in reality, usually the dye-based angiography can only be performed either at the start as well as at the end, sometimes in between if there are any changes in the pathology. But here with the OCTA, which is a non-invasive, we are able to perform the OCTA at every visit and multiple times even during the visit if the image is not captured accurately. I just want to conclude to say that OCT angiography is unable to replace fluorescein angiogram or indocyanine green angiogram 100% because the leakage of the plasma component of the blood is not visualized and hyperpermeability cannot be seen. So again, you see pooling, staining, and leakage cannot be seen. The cyclical delay or inflow delay, as you can see in the patients with the arterial occlusion, cannot be seen, so we are unable to determine the arm retinal time or the transit time. Last but not least, peripheral imaging can be a chore, not very practical and tedious and laborious. However, with the introduction of the swept source or the OCT angio to give us a really wide 15 mm cut, we'll be able to overcome the problem of the peripheral imaging on the OCTA. On behalf of my group of Eagle Eye Center, I just want to thank you for this privilege to be able to share on this platform. Thank you.